Good afternoon, everyone. Thank you so much for taking the time to join us on this wonderful session on a family physician's perspective on elder abuse. My name is Christine Chan. I work for Elder Abuse Prevention Ontario. And I just want to start off with acknowledging that we gather on the traditional territory of a number of First Nations and acknowledge their stewardship of this land throughout the ages. We seek a new relationship with the original peoples of the land, and we seek a relationship that is based on honor and deep respect. Just some housekeeping. All of you are muted and we can't see or hear any of you. However, the speakers will be visible, and please do keep your questions. Not keep your questions, put your questions in the Q&A box, because we'll have a nice chunk of time at the end for your questions and answers. We have Chris and Joanne here to sign language interpret, and feel free to change your view to gallery view or adjust the size of the speakers. You can pull the grid, the box, to make them bigger on your screen. The chat box, you are welcome to post comments during the session, and the Q&A box is for obviously questions. So please put your questions there, because Lisa will be going to the Q&A box to look at the questions for the speakers at the end. The session is being recorded, and all the slide decks that you see today will be with the recording on the EAPO website, eapon.ca. Immediately after the webinar, you will see an evaluation pop up, and we really recommend you telling us your how you felt, your views, so that we can make improvements to our webinars. We want to respect everybody's privacy and confidentiality. We know that we are all working on situations of elder abuse, but let's keep our questions general so that we can maintain privacy for the people and the situations we're involved in. Actually, at this point, I just want to say that for those of you who don't know, Elder Abuse Prevention Ontario, we are a provincially funded, government-funded organization with the mission of we want an Ontario where all seniors can live free from abuse. And I just want to get an idea for who is in the room. So I'm going to run a poll really quickly to see if, tell us a little bit about you. You know, where are you from? Are you a service provider in the community? Are you a service or care provider in the hospital or nursing home or retirement home? Are you a general member of the public? We welcome you. Other professional, you're a family physician. We're particularly interested if you're a family physician. I can see the poll. Jane, can you see the poll as it's being?
Yes, okay. Yes. But I am just, yeah, I mean, it's either a service or care provider in the community, service or care provider in a hospital, nursing home or retirement home setting, general member of the public, other professional family physician, or working in the family physician clinic. So you can actually check off where you're coming from. Thank you very much.
So you can see that the majority are service or care providers in the community, with 60% at the top. We've got a few family physicians here, which is great. And then we have service providers who are working in a hospital, nursing home, or retirement home. That's very interesting. So hopefully that will help our speakers as they adjust what they're saying today. Okay.
Christine, part of the screen is blocked off by vertical blue bars, vertical and horizontal blue bars.
Is that the case for you, Jane, or just?
Yes, it is. And people have been writing in the chat, so I don't know what's happened there.
Interesting. Thank you for.
It keeps on moving around.
Vertical blue bars.
It's almost like a black bar on the right-hand side.
Okay, I got it.
It's covering the presentation.
Thank you for telling me. Is this better?
Yes.
Oh, thank you.
Sorry, everyone. Sorry about that.
Just for your information, Elder Abuse Prevention Ontario, we do education and training. That's our core work. We also coordinate community services, and we work with about 40 elder abuse networks around Ontario. I'm very happy that today we are joined by Jane Teasdale and Lisa Tobio. Jane is the chairperson, is the co-chair of North York Elder Abuse Network, and Lisa Tobio is the chair of the Prevention for Elder Abuse Coalition of Etobicoke and York. So Lisa and Jane, thank you for collaborating with us on this provincial webinar. It's so wonderful to plan and speak to the speakers together. I really appreciate your collaboration. So Jane, take it away.
Thank you. I will be looking at some notes, so I apologize for looking down. But welcome everybody to this wonderful conference we have today. My name is Jane Teasdale, and I'm one of the co-chairs of the North York Elder Abuse Network, along with Natalie Zalaboski, who unfortunately couldn't make it today. I've been asked to do the opening remarks to start this webinar off. Also attending and assisting on this webinar platform today is Lisa Tobio, co-chair of the Prevention of Elder Abuse Coalition of Etobicoke and York. Welcome, everyone. This webinar, Approaches to Elder Abuse, a family physician's perspective, has been well received by the professional community. It has turned into a provincial webinar for Ontario aimed at healthcare professionals and geared specifically towards family doctors, social workers, nurses, family healthcare teams, and community and private agencies. We may have people attending today from other parts of the world, so it will also likely have a global influence, so welcome. You'll be hearing from two very experienced family physicians, Dr. Bachir Tazkarji and Dr. Mark Yaffe. They will cover how family physicians could approach elder abuse and neglect and summarize tools available in trying to identify mistreatment of older adults. The talk will cover the Elder Abuse Suspicion Index, EASI, a validated tool internationally recognized for use in the ambulatory setting. One of the barriers to identifying elder abuse is a general lack of awareness, and this arguably extends to lack of awareness of the person and their life situation. Developing person-centered protocols that are intent on knowing more about the person and relating to that person's specific environment and psychosocial circumstance is clearly an important framework in which all tools should be operating. This means that addressing elder abuse and neglect requires more time and funding for developing the types of informed and trust-based relationships that would allow for assessment processes to be more reliably, effectively, and consistently completed. Empathy is clearly important, but our systems must also be empathic. We all must value the importance of properly identifying elder abuse and for creating the time, the space, and focus to address fundamental needs of the person and society. All our tools, forms, and protocols will be better informed by a fit-for-purpose system and a deep and committed respect for all persons. A systems approach looks to more than one solution and depends on our ability to work together and to develop social capital. What is our individual focus? What is our systems focus? How do we unify this focus and bring to bear greater time, commitment, and resources? Elder abuse is not a box-ticking exercise documentation. We must look at the person and understand their needs and to build up that relationship. I would also like to note that some family doctors need more resources and training in dealing with cases instead of ignoring the situation and turning a blind eye. They may not know of the resources in the community, such as Elder Abuse Prevention Ontario, Senior Safety Line, or that elder abuse networks are available to reach out to. It is time for change for hospitals, family doctors, and health professionals to work collaboratively with elder abuse networks within our region. So reach out. This is the only way really that we can combat elder abuse and to learn how to work together for the rights of older persons experiencing elder abuse. I now have the pleasure of introducing Dr. Bachir Tazkarji. Dr. Bachir Tazkarji is an academic family physician with the University of Toronto Mississauga Hospital. He is currently the education lead and the site residency program director for the family medicine program at the Mississauga Hospital. He obtained his MD from the University of Aleppo, Syria in 1997. He completed his family medicine residency program and fellowship training in geriatric medicine in East Carolina University in North Carolina. Dr. Tazkarji's clinical interests are dementia care, end-of-life care, and elder abuse. So welcome, Dr. Bachir Tazkarji, and I will pass the presentation over to you. Thank you so much.
Thank you, Jane. Thanks, everyone. I'm going to share my screen. Okay. So I think my screen is viewable to everyone.
Dr. Tazkarji, it's just Christine. Oh, good, your video is on. That's wonderful.
Excellent. Well, good afternoon, everyone, and thank you for joining our webinar. This is a topic of passion for myself and Dr. Yaffi, and my goal today is to have a discussion and raise awareness, as well as to provide general information about how to distinguish elder abuse or neglect, how to see the differences between elder abuse and other conditions, as well as to give cases from the perspective of family physicians. So I'm starting with disclosure that I have no ties to any organizations, and as a speaker, I received an honorarium from the Elder Abuse Prevention Network. The objective is to review these forms, risk factors, possible signs and presentations for elder abuse, and review cases from the provider point of view.
Dr. Tazkarji,
yes,
it would be great if you could please just click the screen view, the show the PowerPoint, the show screen, that little icon at the bottom.
That's what I thought I clicked. So like, are you like now seeing the disclosure and then the objectives?
Can you go back to your PowerPoint slide? I'll just show you which. Thank you. So you go share screen. Don't worry, this is normal. Okay, share screen at the bottom. You see near the slide thing at the right bottom, the little monitor looking thing, the TV monitor, yeah. And click on the bottom right.
Yeah, like I see that I shared the screen, but it said your screen sharing is paused. So I'm not sure what.
It's actually, we can see your screen perfectly. Just at the bottom right, see the orange line at the bottom, the orange bar, next to the 0 to 100% magnification. Right. Next to it, yeah, that thing. Perfect. Just click it. That's great.
Excellent.
Is it coming? Have you clicked it?
Yes, I'm like moving the slide. So is it?
Oh, it's not showing. Okay.
Yeah, it looks like there are two slides moving. Why don't you start it from your end, and then I'll just go with your pace. Sorry for that, everyone.
Yeah, no problem. Let me. Okay, I will advance the slides for you. No problem. I'm just going to go off camera.
Okay, thank you, Christine. You can just go to the slide number 4. Okay, that's it. So as I was talking about the objectives, I have the slides in black for a reason, that it's a very sad topic, as you all are aware of, and it's a topic that you don't wish it to any of your patients or loved ones, but yet it's very common health problem. So if we go to the next slide. So definition from the WHO, and if you can remember one thing about the definition, this is a very encompassing definition that goes and talking about like a single or repeated act or lack of action occurring within any relationship of trust where there is an expectation of trust, which causes harm, distress to an older person. Elder abuse has many forms, and we will go over all of those, but primarily, as you are all know, physical, psychological, emotional, sexual, and financial abuse. There is also the intentional neglect and unintentional neglect. Next slide. So, for example, this is a real example just to break the ice. A 67 years old woman attends a family group, support group for her husband who suffers from moderate dementia. They've been married for 41 years. The husband was not listening to his wife. She was very angrily shaking her hand and in a threatening way. Please advance the slide, Christine. And she broke out in tears. The caregiver, the patient's wife, sat with the social worker, and she explained how frustrating it is to take care of her husband, how frustrating it is to be the solo caregiver, and she was having a hard time coping. The caregiver was provided with some support, but 6 months later, she was suffering from a lot of depression after he passed away shortly after that 6 months ago visit. And the wife explained to the social worker that when her husband is not sleeping with any medications or assistance of her, she would wet a towel and she would try to keep hitting him with it, sometimes lightly, sometimes violently, until he feels tired and sleeps. So this is reality. This is one reason for a elder abuse and mistreatment. And as we will go over the talk, you'll see who is at risk and who is more likely to be an abusive. Next slide, please. So this is a sign from the zoo, and if we can learn something, we can at least treat our seniors better than what we hope for our pets or our other living beings. So if you look at the list, it's very long of like, don't disquiet, don't bother, don't tantalize or ruffle. So next slide, please. So forms of abuse, very commonly financial. It may or may not get detected. Psychological, that's by taking away something or not providing a certain service for an elderly. Physical, of course, it's common, but it's not as common as the first two forms of abuse. Sexual, is less common, but it still happen. Social isolation or social embarrassment, preventing the elderly from getting to their loved ones or to their network. And then there is the neglect, whether this is a neglect that's imposed by others or self-neglect. Next slide, please. So who's at risk? When a patient is in the community, who can we think about that he's possible a risk for abuse? And that's for any provider to think about this list when they see signs and symptoms that do not match a story that doesn't make sense to provider. And then it raises the questions, what can I do to help this individual that I feel that there is something wrong going on? Next slide, please. So top of the list, cognitive impairment. So when your patient has mild cognitive impairment, moderate, or a significant cognitive impairment, they're at the highest list of being abused or mistreated. Why? Because they can't advocate for themselves, and if they indicate a certain story, you might think it's of their confabulation. They're delusional, or they're not thinking clearly, especially if they come up with also strange stories all the time. They have seen little babies running around, and now they're saying like someone is hitting them or touching them or stealing their stuff. Well, how many patients with dementia have you heard them saying that so-and-so is taking away my stuff? It's very common, but when do we believe the story, and when should we say that this is a symptom of dementia? The other reason for abuse, dependency on the caregiver. So your elderly patient who may or may not have dementia, but he or she is dependent on their caregiver for transportation, for getting their food, for getting their medicine. This is another area where the elderly is vulnerable for abuse, neglect, or psychological abuse. Family history of abusive behavior. The children or the elderly, the household, they're known to have some abusive behavior. There is evidence of alcohol or drug misuse. And then it comes the financial strain. This caregiver is strained for their finances. Then I will go to the elderly. I'll pressure them physically or psychologically to help me out. And if they don't help out, there will be consequences. The isolation of the patient or caregiver, or both. Then inadequate living arrangements. Next slide, please. Next, yeah. So now someone can say, what are the possible signs for abuse? So how can I detect it if the patient did not tell me? So if you look at this list, if we say lack of access to money or resources, and then skip the second one as these are the physical abuse signs, and then go to the enforced social isolation, that I'm aware of a patient of mine that lives alone or lives far or can't access healthcare often. Yeah, it happens. Unexplained health decline, then poor personal hygiene, and changed behaviors. If you look at everything except for the injuries, you say all of this can happen because of depression, severe anxiety, severe grief. Yeah, my patient who lost a husband, she's living alone, she's in complicated grief, and she started to lose weight, she is not taking care of her hygiene, and she's looking depressed. Yeah, all of this can happen, and all of this can happen with depression or complicated grief. But if you don't think about elder abuse and mistreatment, you will miss it. So if you don't put it as part of your differential and ask appropriate questions or indicate to the patient that you want to check on them and you want to help them, you will miss this opportunity, and it might be late by the time you're able to help a patient. Next slide, please. So why do elderly seldom report an abuse? So that goes back to the list of who's at risk. The elderly are often reluctant to report abuse to the police or other authorities because of fear, because of worry about the lack of their independency. The elderly would say, well, if I report my son or my caregiver, then I'll be thrown into a nursing home or some other place. I don't want to leave my home. Maybe I'll work on it. Maybe things will get better. Maybe if I pay out this loan, things will improve. So this fear and dependency will prevent a lot of elderly from seeking help. The other part is the pride and embarrassment. No one wants to be known that someone is hitting them, someone is embezzling from them, and they can't say no, or even worse, like sexual abuse. Feeling of hopelessness and helplessness, that no one is there going to help me. I'll find a way that doesn't involve a big publicity, and then the neighbors are aware, or some police or something like that. Or the elderly cannot communicate, or as we said earlier, there is some cognitive impairment, and there is a chance of the abuser of accusing the person of being delusional or hallucinating. Next slide, please. I'm going to show you a video, and this is composed in Alberta. In Alberta, there is a mandatory reporting, and I don't want to, I want to point out that people in the community, not healthcare providers, they can report to police, they can seek help for their for people in their community. For physicians and for healthcare providers, there will be different aspects compared to Alberta. I just wanted to point out that this might stimulate discussion about why aren't we like other provinces. So if we can play the video.
Well, you can't. She's just not up to seeing visitors today or tomorrow. Well, it's just not possible. She's not seeing anybody, and she doesn't want to see anybody. No, not even you. You'll just have to wait until she feels better.
Ed, come here. I want that. Ed!
Now she's up again and calling me. I have to hang up. I'll call you soon when she feels better. Listen, Mom, you're just not in a position to have visitors right now. Maybe once you sign the documents, you'll feel better.
But I'm feeling fine.
Mom, we both know you'll feel better once you sign the house over to me. I just don't want you feeling overwhelmed with the burden of the house on your mind. All right. You might as well just go to your room then. Because we have nothing else to talk about until you sign. And And you're not seeing any visitors until this is sorted out.
Oh, I hate these things.
Here, let me do it. What's your PIN number?
1970, your birth year.
Hi, Gloria.
Oh, hi, dear. How are you doing?
It's not working. We'll try again tomorrow.
But Mom, you had money in your pocket.
Come on, I don't want to hear about money we don't have. Let's go. Come on, let's go.
Mary, I'm hungry. Are you on your way out to the store again?
Oh, hey guys.
Oh, Phil, you're back. How was school today?
Oh, there's no school today, Gramps. Just practice.
Okay, I am on my way out. Dad, you stay comfortable. I'll grab some food and bring it back later.
But Mary, I'm hungry now.
You'll be fine for a little bit, Dad. I'll hurry, okay? Can you get your grandpa a glass of water and take him back to his room? Here, Dad, make sure you take your pill today too, okay?
I thought I already did.
No, and you missed yesterday too, so just take a couple of extra. He'll be fine, he just needs a nap.
What'd you say?
Nothing, Dad. You make sure to have a lie down. Okay, I'll see you guys when I get back.
All right, come on, Gramps. Let's go. All right. Almost there, Gramps. Almost there. All right, and oh, yeah, there you go. There you go, Gramps. Let's go.
Wait, you're not gonna just leave him like that, are you?
He'll be fine.
I don't know, man. That just doesn't seem right.
He'll be fine. My mom gave him something that's gonna help him sleep for a while. Come on, we're gonna be late for practice.
You know what? I just remembered. I gotta go home first and get my cleats. So I'll just meet you there, okay?
Okay, yeah. Yeah, I'll see you there.
Okay.
If you or someone you know is experiencing
Dr. Tazkarji, I trust that's where I'm supposed to stop it.
Yes, that's correct. Thank you so much. So I presented this presentation many times, and it's sad seeing this video, but the reality is it does happen, and it happens more often than what we are aware of, and we're not aware of the intensity of it because of all of what we've mentioned why we're underreporting and why we're unaware of all the situations. For the sake of time, I'll go back to the presentation and talk about the few cases that I've seen in the office and how we dealt with it. Then we'll
just want to let you know, Doctor, that there's 5 more minutes. Thank you.
Sure. Wonderful. So, so we'll leave the history and the screening to the next talk. So let's move to the first case, please. Yeah. So the slide before this, Christine. So this is, for example, a note that I got from another provider, specialist that saw one of my patients. And this is what I got. I'll just read it to you. Please kindly consider having social services involved to assess possible abuse at the home of Mrs. And this is abbreviation of the name. Please see attached clinical notes. Please let us know if there are any details. I'm not sure if some of you got similar notes, but the providers don't have a clear path of what to do when they are faced or a patient opens up to them about their situation. Next slide, Christine. So this is a case of a patient, a male patient, 80 years old, who presented in the emergency room with a broken wrist. The patient comes to me and he just says, I fell. I did not question if there is any abusive situation happened because the patient is cognitively intact. Did not think about asking the patient if someone has pushed him. I'm aware of that his son lives with him, but the patient's daughter comes to me and tells me that it was a dispute between her father and her brother, and the father refused to give money to her to his son for to support him. So he pushed him, and that resulted in a fall and a broken wrist. Now, this is one of the situations where you want to help, and the patient doesn't want the help. I talked to the patient. I had a good rapport with him, and he insisted that if anything get leaked or anything gets reported, he's going to change doctors. He will not stay with me, and he doesn't want any involvement. He doesn't want anything to affect his adult son, who clearly is not working and living off of his father. So that's one way of people, their pride and their embarrassment or their fear of consequences to their children takes over, and they accept the abuse. Next case, please. So the second case, about 84 years old couple, their adult daughter, who is a cocaine abuser for many, many years. The parents talked to me about this abusive daughter who was living at some point in her own apartment, lost it all for buying drugs and abusing drugs. And then when she was on the street, they took her back to their home for several years. She never stopped her habit, never refused to go to rehab. And the parents were afraid that a fire will happen in their own home. And she is, when she is high, she's verbally and emotionally abusive to them. So they sought help, saying like, can you put her in a hospital forcefully against her will on a Form 1? Unfortunately, we cannot do that if she's not meeting the criteria for Form 1. However, we help the family getting a court order from the Justice of Peace to help those two elderly with eviction for their daughter. Next slide, please. I'll skip for this case, and if we have time, we'll go back to it. We'll mandatory reporting or not, we'll talk about it a little bit with the next talk, but pretty much if it's in a nursing home or retirement home, it's mandatory reporting. And if you're living in Ontario and you want to call the helpline, it's for direction and to help providers of navigating what avenues they can help their patients with. It's not a police line that will help the patients. So that's important to distinguish. At this point, community mandatory reporting is not available in Ontario. And that's all from me. Thank you so much.
Thank you, Dr. Tazkarji, very much. And I really enjoyed definitely the videos and definitely the case scenarios. I think that's something maybe we can do another session where we can do breakout sessions with regards to the scenarios. So now I would like to introduce Dr. Mark J. Yaffe. I'm not going to read his whole bio because there was quite a bit, and I think we want to leave the rest of the time after the presentation for questions. So Dr. Yaffe is a McGill University professor of family medicine who practices in the Family Medicine Center FMG-U of the St. Mary's Hospital Center within the Integrated University Center for Health and Social Services of West Island of Montreal. He has been practitioner of and advocate for teamwork and interdisciplinary care with particular interest in chronic disease management, family caregiving, and elder abuse. In 2014, this was recognized by the inaugural Award of Distinction for Care of Older Adults by a family physician within and beyond the walls of one's practice. Awarded jointly by the College of Family Physicians of Canada and Canadian Geriatric Society. So thank you, Dr. Yaffe, for attending today.
Thank you very much. I am trying to do a shared screen here, and we seem to.
So great. It's working, Dr. Yaffe.
It's working, she says.
Just have to find your presentation.
Okay, I'm waiting for that. So you're looking for the presentation at your end, I assume?
No, I'm not. I'm looking at we're looking at your screen. Are you going to drive your slides?
Or you were going to take it from the deck and I was going to share it from there.
Sure. Okay, so I'm gonna share mine. Okay, here you go.
Good, thanks very much. We'll just move on here once I get my act together. The mandatory disclosures, whoops, something's happening here. Thank you. The mandatory disclosures, my elder abuse research funding has had no commercial sources. It's come from the Canadian Institutes of Health Research, the Public Health Agency of Canada, and specifically the New Horizons for Seniors program. In terms of conflict of interest, I clearly have conflict of interest this afternoon in that I have been the principal investigator or co-investigator on projects that develop 4 tools to help detect the elder abuse situation. But the reality is that's why I've been asked to talk. And so I will present the tools that I've been involved with and will share both strengths and limitations of those tools. I hold 2 copyrights on the tools, but there is no personal financial gain from the tools or from those copyrights. And this afternoon, I'm receiving no honoraria for presenting this afternoon. The objectives of my presentation are to look at the context for elder abuse identification, to look at limitations of tools that have been available to identify mistreatment of older adults, to introduce the Elder Abuse Suspicion Index, which is an internationally recognized validated tool available in 15 languages for use in ambulatory care. And Christine, if there's a way to get rid of the blue vertical bar, that would be wonderful. I'm going to present an overview to how this EASI tool might be used, along with, as I said, some strengths and limitations to it, and give brief mention to 3 spin-offs from the EASI, which have been developed for use in other settings. Next, please. Context for looking at elder abuse, just to remember how prevalent elder abuse is in the ambulatory setting. The literature has been very disparate, ranging anywhere from 1% to 18%, but the most current data out of the US is that about 10% of seniors in the ambulatory setting are abused. In the international literature, about 16%. Elder abuse, as we have learned from Dr. Tazkarji, often goes unreported, ranging anywhere from 1 in 15 cases to as many as 1 in 6 cases not identified. There are, as implied by his cases, social considerations as to why abuse may or may not be reported, and we must identify and recognize that elder abuse represents both an overt and covert reason for many older adults being assessed in the emergency room. Overt, obviously, being somebody who inquires about why somebody has fallen and ended up with a fracture. Covert being those for whom the fracture is identified, treated, but no investigation is made into the cause of the fall. A very important consideration in thinking about elder abuse is the recognition that it is a premature cause of mortality in older adults. A landmark study published by Mark Lax and colleagues in 1998 was a prospective 13-year cohort study of some 2,800 community dwelling seniors who were followed over 13 years and then examined for all factors related to their health and to their mortality. When the 2 groups were compared, that is the abused group against the non-abused group, the non-abused group showed a survival of 40% compared to a low survival rate of only 9% in the abused group. This was after one had taken into account anything that might have actually been the act of abuse. And therefore, the authors concluded that there had to be something going on in the process of elder abuse that affected the organism, the human being, that resulted and promoted premature death. This is not an isolated finding. If you look at orthopedics, for example, and you examine people who have undergone, elderly people who have undergone surgery for a hip replacement is a relatively uncomplicated procedure, and there is a small mortality rate related to the procedure itself. But in fact, the greatest mortality occurs sometime a year after the surgery has taken place. And that suggests, again, that something goes on in the homeostasis of older adults that results and precipitates a premature death. Elder abuse is this type of example. Next slide. Barriers to detection, what doesn't really make much difference where you're coming from, what your discipline is, lack of awareness about elder abuse, what it looks like, and the negative social and mortality implications that I've just alluded to. As well, over the years, there have been ambiguous clinical practice guidelines. Depending on what country you come from, the guidelines are for screening, against screening, or uncertain about screening. Today, most of the guidelines say we're not really sure, but there seems to be no harm and some potential benefit. Others have said, it's not my job, therefore I'm not going to get involved. Fear of offending patients, confidentiality issues that may arise between the health professional and the person who is disclosing. There may be reluctance on the part of the victim to report, and amongst many, a belief that detection won't lead to a solution. Next. Other barriers to detection include uncertainty about how to inquire about it. Most tools that have existed have been lengthy and used indirect inquiry. As well, when one approaches older adults, there may be misinterpretation of signs and symptoms, commonly referred to as geriatric syndromes, and geriatric syndromes commonly mask signs and symptoms of abuse. The most common, for example, being extensive bruising in the elderly that are attributed to the use of anticoagulant medication, when in fact, as often may be the result of physical trauma in the home. An unfortunate situation in terms of barriers represents how one is exposed to the literature on elder abuse. Within the United States, there is a reputable web-based resource for doctors that has over 400 topics that they can study online. If you go to this particular site and look for elder abuse, you will not find it as a identifiable title, nor will you find it under geriatrics, nor under elder care, nor under aging. But you will find it in a section under legal and ethical issues. Question therefore comes up, is all elder abuse of legal consequence? And if it is, to what degree? And if it is it still necessary to put this in a medical website under legal? And that's not where doctors would commonly go to look for information. Next slide. If one is considering trying to identify elder abuse, one thinks about the use of screening tools, and there have been some fundamental principles that have been put forward. The fundamental function of any assessment tool is to guide practitioners through a standardized screen to ensure that signs of abuse are not missed. And the choice of a screening tool should take into account a balance between brevity and comprehensiveness, and the tool should do more harm. The tool should do more good than harm, excuse me. Next slide. Screening tools are assessed by two principles. One is the idea of sensitivity, and the other is that of specificity. Sensitivity, to be important, means that a high proportion of those who screen positive are in fact truly positive. And one looks for a screening tool with a sensitivity of a value of 0.8 or 80%. One also looks at a concept of specificity. And a high specificity means a high proportion of those who screen negative are actually negative. And again, one looks for a value of 0.8 or 80% or above. Next. On this slide, I'm showing some detection tools that in the early 2000s were commonly used and may still be commonly used to look for elder abuse, but all had limitations and most did not conform to the criteria that I laid out in the previous slides. The indicators of abuse, 29 questions, a lot of training required, takes 2 to 3 hours to administer, and is administered in the home. The elder abuse assessment instrument consisted of 51 questions, usually used in emergency rooms by nurses and time-consuming given the length. The base or brief home screening of elderly consisted of 5 questions, required special training, and commonly used in the home setting. The case, 8 questions, and was interviewing caregivers, keeping in mind that the caregivers may be the abusers. The Wallach-Senstock elder abuse screening tool, 14 questions of a yes or no nature. It's an excellent tool, one of 3 tools recommended by the Centers for Medicare and Medicaid in the US. And then the vulnerability to abuse screening scale, or VAS, was adopted by the Wallach-Senstock, 12 questions, yes or no, also recommended by the Centers for Medicare and Medicaid. Next question, next slide, please. The question that we came up with was, could we do a little bit better than some of these tools and make them more appropriate for use by doctors? our research team made certain assumptions, and that was that doctors are well positioned to see lots of elder abuse because of their frequent contact with patients, either in their offices, in emergency rooms, or on hospital wards. On the other hand, when our research started, we knew that doctors didn't like to use screening tools, and that none of the existing screening tools that I presented a few slides ago would be appropriate for doctors. Our final assumption was that if we could develop a tool that could be used and would be acceptable to doctors, then for sure it could be used by other professionals. Next slide, please. The conditions that we set out for a physician to detect elder abuse, we went to the literature. The literature told us, firstly, you had to have awareness of what elder abuse was, plus a high index of suspicion. Secondly, that American geriatricians commonly problem solve on the basis of the same thing, high index of suspicion. And finally, the strong predictor of doctors seeing and reporting elder abuse is having direct questions to ask. And one of the difficulties with the previous tools that existed was the absence of direct questions. Next slide. This led us to set out to create the Elder Abuse Suspicion Index with the emphasis on the word suspicion. We never said that it was a screening tool, and that wasn't the goal. And I'll clarify that in a moment. Our team consisted, beyond myself, of Maxine Lithwick, a social worker in Montreal, who was one of Quebec's early leaders in the field of elder abuse, Christina Wolfson, a leading Canadian epidemiologist, who is currently one of the principal and co-investigators on the Canadian Longitudinal Study on Aging, and Deborah Weiss, who was one of Dr. Wolfson's graduate students. On this slide, I have listed the reference for the Elder Abuse Suspicion Index that you will be able to access, as well as in red, the website for the EASI tool and information about its background, its use, and the tools that have been derived from it. Next slide. Could a tool aimed at doctors be used by other disciplines? What happens when experts on a common topic, but coming from different disciplines, are asked to reflect on the same words and the same ideas? Next. We set out 4 discussion groups. We set out to get individuals with expertise in elder abuse, whether they came from clinical, research, or teaching settings, and had 4 groups, 3 comprised uniquely of social workers, another of nurses, another of doctors, and then 1 composite group from all 3 disciplines. And we asked them to discuss and critique 9 possible questions that we thought might be included in a tool that we were creating for suspicion. We ended up with 10 social workers, 10 nurses, and 11 doctors. Next, please. What came out of the discussion? Well, predictably, lots of disagreement. There was disagreement around word content, about their meanings, about explicitness of words, about the risk of offending older adults, about the question relevance, about the type of language that we were suggesting, about the ease of asking the questions, the order of asking them, and how long the questions were. On the other hand, after we took some of that into account and went back to the group and made some modifications, when all 31 from the various disciplines that we had involved were asked to independently identify their preferred questions, out of 9, all chose the same 5 questions, which is what we asked them to narrow it down to, and all agreed that we could ask those questions if we introduced them in a non-threatening fashion. And that was an introduction that said, I'd like to ask you a few questions about events that may occur in the lives of older adults. In that way, we were never telling anybody that we were asking specifically about mistreatment or about abuse. We were identifying events that unfortunately commonly occurred in the lives of older people. Next. So what did our tool look like? It consisted of 6 questions. The first Questions 1 to 5 would be asked of the patient or of the client or whatever you wish to call that individual. The 6th question would be asked and answered by the doctor or by anybody else who was asking it. And the context was for the last 6 months. The first question had no bearing whatsoever on abuse. It was a question related to dependency. Have you relied on people for any of the following? Bathing, dressing, shopping, banking, or meals? Yes or no? The purpose of this question was solely to prime the respondent to think about their life and to think about situations in which they might have difficulty. Question number 2, address neglect. Has anyone prevented you from getting food, clothes, medication, glasses, hearing aids, or medical care, or for being with people you wanted to be with? Yes or no? As I'm going through these questions, think about Dr. Tazkarji's little video, and you'll see the relevance here. Question number 3, address psychological or emotional problems. Have you been upset because someone talked to you in a way that made you feel shamed or threatened? Yes or no? Next slide. Question 4, has anyone tried to force you to sign papers or to use money against your will? Yes or no? That was financial or material. Question 5, address physical or sexual issues. Has anyone made you afraid, touched you in ways that you did not want, or hurt you physically? Yes or no? Question number 6, as I mentioned earlier, was not asked of the older person. It was addressed to the health professional. Elder abuse may be associated with findings such as poor eye contact, withdrawn nature, malnourishment, hygiene issues, cuts and bruises, inappropriate clothing, or medication compliance issues. Did you notice any of these in the last 12 months or today? Next slide. So when you looked at the EASI response options, you had the option of a yes, option of a no, and occasionally on some of the earlier versions, a don't know, or when you ask the question, the person doesn't answer. It has no statistical impact on the tool, but a failure to respond may raise questions and increase your index of suspicion. And what is your index of suspicion? Any answer of yes on questions 2 through 6 would raise suspicion sufficiently to say elder abuse is possible or likely and needs follow-up. Next slide. So what are the characteristics of the EASI tool? It asks direct, brief questions, as I mentioned, most commonly not seen in other tools. It generates a reasonable level of suspicion to justify referral to a community expert in elder abuse for further evaluation, whether that is a social worker, adult protective services, law enforcement officer. The tool was validated using a significantly large sample size of 663, which is pretty well unheard of in elder abuse research, looking at people aged 65 and over who had mild cognitive impairment or better and inquired about in an office setting. Another characteristic of the tool is because it is short, it can be repeated over time to desensitize people to discussing their lives, a benefit when victims appear reluctant to admit to things that may suggest abuse. The tool is currently available in 15 languages on our EASI website, and this is the benefit of collaboration with colleagues throughout the globe, and it's been a wonderful collaboration. It's the only tool that in 2013 was recommended by the US Preventative Services Task Force on Elder Abuse, and it's one of the 3 tools recommended in 2014 by the US Centers for Medicare and Medicaid. Next, please.
Just letting you know, Dr. Yaffe, you've got 5 minutes.
Perfect. Next, please. There is no apparent harm in the use of the EASI tool. We showed this in our own study in which we developed a self-administered version of the EASI and then did a follow-up with the seniors, and the acceptance of the tool, of its wording, and of its goals was almost universal. The U.S. Preventative Services Task Force that I referred to earlier has also found no apparent harm from easy use. And Holly Caldwell, in her 2013 PhD thesis, did focus groups with people using the EASI and again reported no apparent harm. Next, please. We have gone beyond the EASI, and on our EASI website, there are 3 additional versions of it. There's the self-administered version called the EASI SA. There's the EASI LEO, which was created for use with law enforcement officers in the field. And this was work initiated by the Public Health Department at Yale in the US. And finally, we have recently in Montreal created the EASI LTC for use in long-term care settings. And we have published that tool as well. Next, please. Why do we think the tool is easy enough to use? The doctors in our study were positive about it. 72 out of the 104 doctors who used the tool, 95% found the tool somewhat or very easy to use. 2/3 said it took them about 2 minutes or less to use. 97% felt it had some to big practice impact. 2/3 said the use of the tool just gave them a very good awareness of what elder abuse looked like and confidence in what to look for. And 80% thought it would be somewhat or very useful in practice. Next. What are its properties? Its specificity, 0.75. You'll recall that I said we looked for tools in the best scenarios that were in the range of 0.80. Well, we were almost there on the specificity part of it. So the specificity is pretty good. Our sensitivity was 0.47, which is only fair, reflecting back on the 0.8 that I mentioned earlier. But at the time we did the study, it was the only published tool that has been validated for use in the primary care setting. And its sensitivity was equivalent to all of the longer tools that were used. So we developed a tool that was as sensitive as the existing tools, but brief and easy to use. Next, please. What can other professionals expect of the tool? Can they use it? If you're a pure epidemiologist, you would say that only family doctors and ambulatory care could do this, to use the tool. So since it was the context of this tool that the EASI was initially validated. However, as I described to you, it's the product of input from an interdisciplinary team. And we've been able to show that the tool has positive face validity in a World Health Organization collaboration in 8 diverse countries that are listed on the slide. And in those collaborations, nurses and other folk use the tool. As well, we have been able to demonstrate through international correspondence that the EASI is being used by social workers, nurses in emergency rooms and geriatric clinics, occupational and physical therapists, community-based social workers and psychologists, dental hygienists, orthopedic clinics, and so forth. Next. How to use the tool. The EASI website contains a form to request approval for reproducing the tool for clinical use. There's no cost for non-commercial activities. For potentially profit endeavors, for example, incorporation into electronic health records, journals, books, software. Whoops, we lost the slide, thank you. Help. Yeah, for the potentially profit endeavors, the EASI website form must be completed. The tool should be used verbatim unless specific changes are approved by the authors. The questions should be contextualized to reduce the sense of threat. And I suggest that I'd like to ask you a few questions about events that may occur in the lives of older adults. Questions should be asked in order to go from less to more disturbing, and an answer of yes on questions 2 to, and this should read Q, questions Q 2 to 6, not Q to 5, should be flags for suspicion. Next, please, we're almost done. What to do if the EASI is positive? Does the suspicion index oblige one to report? This is not a formal screening tool. It is validated, but we do call this a suspicion index. And if such, If there is no sense of urgency, it might be worthwhile to see the person again and ask permission to repeat the EASI. Also, is there an obligation to act or report? This depends on your profession, your time, and your ability to engage in a more detailed inquiry at the time that you use the EASI or at some other visit. And if you do get a positive response, do you want to report before you've had the opportunity to assess for medical competency? If there is evidence of incapacity, it's important to differentiate between a condition of delirium, which is often treatable, versus dementia, which is not treatable. And both of those conditions may alter the credibility of the response. If you do demonstrate incapacity, it's important to ensure protection of that person as per the norms or expectations of your profession, and caution about contacting next of kin because they may be the abusers. And with seniors' permission, you may want to refer to the more experienced people, as I've already mentioned. Police, adult protective services, social services. Next. What can one expect if you are going to those resources? We expect that, dependent on your location, you can expect an evaluation of psychosocial needs of the older person and the caregiver. And if indicated, one may begin procedures to have the person declared under a protective regime, be that public, private, curatorship, or homologation of a mandate. One may want to initiate home care services or respite programs. And importantly, if the person is competent, to recognize the right of self-determination and the support of that person to a life without abuse. Next. Mandatory reporting. Very briefly, some jurisdictions have mandatory reporting laws, and you need to find out what applies in your areas. But the definition of mandatory varies. Does it mean all locations of abuse, or does it mean abuse that is limited to institutions? I've listed some references here, and we can address other issues in the question period. Thank you.
Thank you so much, Dr. Yaffe. That was wonderful. And Dr. Bachir before that. I'm going to invite you both to come back on. And Lisa, who is the chair of the Etobicoke Prevention Coalition of Elder Abuse in Etobicoke in York. She's going to run the question and answer session. Lisa, you okay?
I'm great. Thank you very much. And thank you for allowing me to do the question and answer period. A lot of the comments have been that the presentations have been excellent, and I thank you for that. I know for us, it's key that the doctors are involved with elder abuse cases. We've had a lot of cases come through our office, and without the support of the doctors, sometimes we get nowhere. So I thank you for being very supportive of seniors within the community, because like I said, I know it's key, especially in Ontario. So the first question is for both doctors. How do family physicians distinguish between dementia symptoms and PTSD symptoms, as they may not even be officially diagnosed by a psychologist?
Dr. Tazkarji, you want to start?
Well, I don't think it's the scope of this talk, but the dementia has a specific criteria to diagnose it, as like the cognition and the activities of daily living, plus the behavioral changes. So if the patient is positive for these screening tools and the history do support dementia, then that's certain dementia. Patients with PTSD don't have necessarily any cognitive impairments. That's it from me.
I would agree that it's very difficult to summarize it in these talks, but there are screening tools available for PTSD and for dementia. And in our offices, we would likely use those as an initiation into investigation, and then refer to a psychogeriatrician for further assessment.
Thank you. The next question, when a physician working at a private retirement home does not listen to a SDM to the point of clear neglect and abuse results, what can be done?
Want to repeat that, please?
Sure. When a physician working at a private retirement home does not listen to a SDM, I guess the main decision maker, to the point of clear neglect and abuse ended up resulting, what can be done? So it sounds like, sounds like the physician wasn't listening to the SDM for the senior, and neglect and abuse then resulted.
It often depends on the milieu in which this takes place. If this is institutional and one is observing that one's needs are not being addressed, most institutions are supposed to have an ombudsperson or a director or somebody who is responsible to the patient and family to whom one can go and lodge a complaint. If one does not get a response from the institution, again, in most provincial jurisdictions, there are government people that one can approach. And finally, or not finally, but if one is in an institution, that does not stop one from seeking the advice of adult protective services in the community or from one of the elder abuse agencies to help step in and get advice on this.
Thank you. The next question is, what approaches do you use or recommend when supporting Indigenous elders who are experiencing abuse and violence?
I am going to state straight out that I am the worst person to be asked that question, in that any answer that I give you will be theoretical. I have precious little experience in dealing with individuals from Indigenous populations, and I think it would be inappropriate of me to try to suggest an answer to that question. It is a serious question and it needs to be addressed. I don't have the expertise to answer it.
Yeah.
Doctor?
Unfortunately, same here.
Same? Well, thank you for your honesty. Okay. Dr. Yaffe, your comments seem to suggest that family and geriatric doctors seem to lack education and direction from their professional organizations. Why does this lack of education or direction exist? And are any efforts being made to rectify this?
Okay. I think we have to be careful because I think this is in part a generational issue. Within medical school training, within residencies in family medicine and in geriatrics, elder abuse has been incorporated into the curricula at least for the last 10 or 12 years. And I'm familiar with that because I helped make recommendations about that sort of thing. And it has been included in the curricula of continuing professional development programs that some family doctors and some geriatricians attend. It's going to take a lot of time to provide our colleagues with the knowledge base, the confidence, and the support that they need to address these issues. And I would say as well, and I've shared this with some of the members of the panel, there's a bi-directional responsibility. There's a generation of family physicians who, at least in the community in which I work, who have lost confidence in the social work community, in that they would refer patients to social work, and once the patient ended up in social work or adult protective services, they lost their patient effectively and had no feedback. And so when we talked at the very beginning and the idea was mentioned about the importance of interdisciplinarity, I think that is one of the issues. The outreach that the social service has made to family physicians and geriatricians, I think has been quite impressive and quite helpful and needs to continue. But it's also important to recognize that family doctors need feedback to reinforce the work that they're doing. And that feedback means that if I refer a patient, a client to you, and you investigate and determine abuse or non-abuse, then surely I should be getting that information back. And that just reinforces the value of me identifying and flagging. If I don't get that feedback, then I'm not going to likely be keen on doing this again. And this is not unique in the relationship between family medicine and social work. It's historically the relationship between family medicine and specialty disciplines. Family doctors for generations have referred their patients to specialists for consultation. And at times, those specialists didn't send back a consultation note to let them know what happened to patients. So it's a universal problem of communication within health and social services that we have to improve on. And the elder abuse issue represents one silo within it.
Thank you. Dr. Bachir, what percentage of elder abuse is reported, what percentage of elder abuse is re-reported by unrelated people as seen in the videos?
Unrelated individuals reporting would be in the community, like encouraging people to report to police. Often unrelated individuals will not report to healthcare providers unless that provider is doing a home visit or being involved, seeing someone in the community. Maybe the elder abuse network receives phone calls from unrelated individuals, but healthcare providers will have no way of knowing if neighborhood individual is watching or witnessing an abuse.
Thank you. Dr. Yaffe, in Montreal, are you able to call police and request a wellness check if there is suspicion of abuse?
Are we able to call police? Yes. What do they do? I would say I don't have a good sense as to what they do. And as a general rule, I try and avoid bringing police in until I have had the luxury of contacting one of our elder abuse referral centers to discuss the case and to get a more informed perspective before I bring in law enforcement that can be threatening and potentially damaging to a family, notwithstanding the expertise that the law enforcement officers may bring to the situation.
Thank you. Are there any tools, this is for both doctors, are there any tools for moderate dementia or Alzheimer's?
We're talking tools for elder abuse, is that correct?
Yes.
I assume.
Yes.
Our elder abuse, our EASI LTC, which is for long-term care, we have submitted for funding to be able to assess the feasibility of its administration for people with moderate dementia or better. It will be probably, assuming we get our funding, it'll be at least 2 years before we will have the answer to that question. If we are able to show that, in fact, the modified tool is usable in a long-term care setting with moderate dementia, I think it is important to remember that even when we label somebody as being as having severe dementia, some aspects of dementia are encapsulated, and that people may retain capacity to respond to certain particular problems, which is why those of us who care for elderly occasionally are asked to be involved, for example, in a situation where somebody wants to modify their will, and yet they've been identified as being severely having severe dementia. Yet when you spend enough time with them, you find that within the encapsulation of the will and the intent of what they had in the will and what they want to change, that they are in fact competent to change the will. So I think one needs to be cautious about the label that one puts on the individual. And if one thinks that somebody with severe dementia is being abused, it will require repetitive visits to that individual, looking for consistency of response, looking for corroboration, perhaps from others, and using the benefit of time and perhaps other members of the interdisciplinary team to provide feedback as well. Not easy, but you may be able to show it in some cases.
Thank you. Dr. Yaffe, has the EASI tool been translated into languages, including Indigenous languages?
The EASI has been translated into 15 languages, and they are available on the EASI website. They have not been translated into Indigenous languages. It is something that clearly is a desired feature. The process of translation is exceptionally difficult to do, and I would certainly welcome being approached for collaboration on this. In the cases where of the 15 languages that we have on the site, English and French were the two that we did and validated. The remaining 13, we were approached by particular ethnic communities around the world to assist with in doing the translations. So I would welcome any Indigenous community who wish to work on this. I'd welcome them to approach us and see if we could work on something.
Thank you. I think this is the final question. Oh. Sorry, I just lost my screen.
Just wanted to thank everybody for your many questions and comments. They're all very good, and I wish we had another hour, but maybe we need to have Dr. Yaffe and Dr. Tazkarji back there for another session. Jane, what do you think?
I definitely think so. I think there's a lot of, important questions that have been asked by the attendees. Unfortunately, we didn't have, time to do that, but definitely I think a way that we could do breakout sessions somehow to go through these. But thank you for sending, I've been reading through them. And again, if you have any other information, you can certainly contact Christine. I think she put her email into the chat box. So again, thank you for coming online.
Just for the sign language interpreter, my email is gta@eapon.ca. Lisa, did you have one more question before we let these gentlemen go? No?
Perhaps
There's one question regarding, there was one question to both doctors regarding their clinical experiences with elder abuse And what do you feel is the best approach?
A very broad question. I'm not sure. I'm not sure how to approach it. I think that the most important feature for me is that every case, and I know the word case is not a popular term. Every situation should be treated as unique, and one should not make assumptions. I've been asked to consult on some cases in which I am sent material and I make a judgment, and then of course sit down with individuals and ask appropriate questions. And I am as often wrong as I am right, and so I think individualizing, caution, openness, and maintaining fairness to all parties so that nobody feels that you are singling them out until one is sure about what one is talking about. And then again, don't do it all on your own. You need help with these things.
How about Dr. Tazkarji?
Yeah, like I would go with the gut and not to feel that there is something not fitting and not sitting right, and not to inquire more. And don't worry alone. It's a team approach, so involve organizations that are around you and collaborate with whoever can support the patient in question. Often a physician, if they're able to do a home visit, that would be very helpful to know the situation on the ground. If the patient is unable, then maybe support from the community, if there is like a community support for a outreach, that they can provide that service. I tell my residents, don't worry alone. There are many services that can help you, and there are reporting agencies. So for the individuals who was asking about help at the retirement home, this is easier. There are organizations that supposed to investigate allegations of mistreatment and abuse. So you have a reporting mechanism. Thank you, everyone.
So I'm going to give everybody a chance to say a 10-second goodbye. But before that, just bear with me. I have some announcements to make. So for our participants, there are supports for older adults in Ontario. A good one is if you only have 2 minutes with an older adult, why not give them the senior safety line? A live counselor will answer the phone, and they can take up to 200 languages, and they can have a real-time interpreter on. So that's 1-866-299-1011, 1-866-299-1011. On tomorrow we're going to have Maureen Pollard. She's a registered social worker, and she's going to be speaking about self-care. You know, for all of us working in this field, it's not easy, and we suffer vicarious trauma and moral distress. So let's meet tomorrow to look at what Pauline has to say and her tips. And then on Thursday, we have Margaret McPherson and psychologist Dr. Peter Yaffe. They're speaking on preventing domestic homicides with older couples. So you don't want to miss these two upcoming webinars. So why not sign up for our newsletter, and you can get all the webinar notifications. Do fill out our evaluation. It will only take a minute. And now I'd just like to go around the table and ask maybe the two doctors, Dr. Tazkarji, Dr. Yaffe, to say a goodbye, and then Lisa and Jane. Dr. Tazkarji?
Thanks for the organizers, and thanks for the Elder Abuse Prevention Ontario, and for the attendee, and goodbye.
Dr. Yaffe?
Thank you. I appreciate the invitation to be part of this webinar, and thank the organizers for doing so. I've enjoyed listening to the discussion and to the questions. And the only thing I would add is perhaps if you could add into the chat line the EASI website that is on our initial slide. It may make it easier for people to find it, because the website actually does not have the word EASI in it.
What is it, Dr. Yaffe?
www.mcgill.ca. If you look on my first slide.
Oh, it's okay. I will put it in the chat box.
Right.
Lisa and Jane wanted to invite you to say goodbye, but Joanne and Chris, our sign language interpreters, you did a great job. Thank you. That's Joanne. Lisa and Jane.
I'm sorry, I'm cutting out. Thank you to the doctors. I could tell the people that were on the webinar today very intrigued and very happy to hear your presentation. So thank you.
Yes, and I'd like to say thank you to Elder Abuse Prevention Ontario for organizing, and a shout out to Christine Chen, and definitely the doctors. Both of you did amazing presentations, and I think, you know, these are topics that we continue to discuss and work out, you know, within our, I guess, our areas of the city, how we can better work together with family doctors and with hospitals. More collaboration, definitely more empathy, and person-centered care, and understanding your client and building up the relationship in order to have those conversations with them. So thank you again for bringing these important discussions to Zoom. Thank you.
Thanks, everyone. Lovely to work with all of you. To our participants, have a great afternoon, and we'll be back again tomorrow with another webinar.
Excellent. Thanks, everyone.
Thank you.